I just will try to go through fairly quickly, but we've gradually developed a new approach to leprosy control because the old approaches don't seem to be working. And this is really what I'm going to be talking about is a partnership between two non-profit organizations, American Leprosy Missions, which has funded the development of a new leprosy vaccine by the Infectious Diseases Research Institute in Seattle. And there are obviously a lot of other donors who've assisted us and a lot of other clinicians and scientists involved, but these are the two main organizations. And leprosy is a complicated disease. I'm just showing here a graph of how the immunity to leprosy is high right up on the left. Most people never get leprosy because they have a high enough immunity never to get the disease. And that immunity decreases towards the bottom right, and it's a cell-mediated immunity. And as the immunity declines, people who get leprosy, they have a higher and higher disease bacillary burden. And the disease is very different across that spectrum, which is what makes leprosy a very fascinating disease. And this is just a picture of someone who has very multibacillary disease. He has 10 to the 11 bacilli in him. And he came to a clinic and said he had a history of 4 years of having these nodules, and probably most people shorten the time of their history, so it might have been longer. And we also think that people are infectious long before they even have any symptoms. So he has probably been infectious for at least 10 years, and we think that is a big pool of people who are continuing the spread of leprosy. And certainly diagnostic tests, which were mentioned earlier, are a very big focus in leprosy, and a lot of effort has been spent to diagnose people earlier, but it's been very difficult to get tests that are both sensitive and specific enough to work. So this is the picture of leprosy throughout the world, and I really want to look at the bottom line, this green line, which is the rest of the world excluding India. And over this is 30 years of data, and over that period there has been various attempts at elimination. But if you look at that bottom green line, it doesn't really seem to have made much difference to the number of new cases that are occurring worldwide. And even the more recent figures are probably, there's a lot of underreporting. If you go to the data, many countries in Africa have stopped reporting since the elimination campaigns have been concluded. And if you look at this study, which we did in the Philippines, over a period of 10 years, of all the children under 15, this is the spread of their ages, and people are still getting leprosy at the age of 5 and under. And that means that leprosy transmission is still very active, and many countries, over 100 countries, have this picture of there's still children getting leprosy. So one of the issues is that we don't know an awful lot about transmission. So here is what we do know. Household contacts have an increased risk, and the majority of cases are part of a larger pool of contacts. And in low endemic areas, you tend to get more cases amongst contacts. There is an armadillo reservoir in southern United States, which has just been reported, but that seems to be an unusual situation. And also there are case reports of transmission through contact, skin to skin, but that also doesn't seem to be the typical route of infection. What we don't know, because M. leprae can't be grown in vitro, we don't really know how widespread it is and how persistent it is in the environment. So in a household where people are getting leprosy, we have no idea really the dynamics of the bacillus within that environment. And the porcibacillary cases, those are the ones with some immunity and very few bacilli. We don't know if they, never transmit leprosy, or whether they go through an early phase of having a large bacillary load, and then they and possibly transmit the disease and then have less bacilli. But it may just be only the multibacillary ones who transmit the disease. No other environmental reservoir has been conclusively demonstrated. Primates don't easily get leprosy, and even with the armadillos, we don't know exactly how it's transmitted. So we know it's the same strain in humans and armadillos in the southern United States, but how they interact, we don't know. And as I mentioned right at the beginning, we don't know when these MB cases become infectious as they incubate leprosy. It's a very slow process to build up a large bacillary load, so we presume they become infectious relative in the middle somewhere. So what we're wanting to do is move on from a case finding and chemotherapy strategy to a strategy of post-exposure prophylaxis through contact examination. So if you examine contacts, you find some new cases early, and chemoprophylaxis has already been trialed. There's been a very good trial in Bangladesh which shows that there's a 57% protection from a single dose of rifampicin over a short period, over 2 years. And there's other supportive evidence from Indonesia that a single dose of rifampicin is a good protective measure in contacts. But it's not perfect, and we have various research challenges. So we want to do operational research to implement how to implement the contact examinations, and there are a lot of questions around that. Integrating contact examination into routine health services, way of doing that, how many contacts should be examined and given the chemoprophylaxis, what about informed consent and ethical issues, and is there a problem when stigma is high? So these are operational issues that we're starting to look at, and there is also the possibility that chemoprophylaxis could be enhanced. So for example, a higher dose of rifampicin or other drugs such as rifapentine or drug combinations. And so it's possible that you could do diagnostic tests and see who would benefit more from different regimens of chemoprophylaxis, but that's quite complex. And all of these advances or changes to a chemoprophylactic regimen would require clinical trials, so that's quite a big investment. But one of the things that we are now looking forward to is enhancing post-exposure prophylaxis through immunoprophylaxis. And in the past, various vaccines have been shown to have some protective effect in contacts of leprosy cases. So BCG was used, and then various other mycobacterial species, MW, MVACI, these have been used. But actually, they're all fairly similar to BCG. And if there is a protective effect, it seems to last for at least 8 years. And the effect is quite variable between different countries. And it seems that probably when people have had BCG vaccine at birth, BCG is not a very good booster. So we have, going back to this partnership between American Leprosy Missions and IDRI, we developed a new vaccine over about the last 12 years, and it's now ready for phase 1 trials. So the goal is that it would be an adjunct to chemoprophylaxis to both boost the previous protective effect of BCG, which has been given at birth in most people nowadays, and prolong the protective effect of chemoprophylaxis in contacts of leprosy cases. So this is the vaccine. There's no patent, so anybody can go and manufacture it who like. But it's 4 antigens from the leprosy genome, and these boxes just show the protective effect in the mouse foot pad, which is not a particularly good model, but it is at least suggestive of that some protective effect will be gained. And the adjuvant is an adjuvant also developed and owned by IDRI, which stimulates cell-mediated immunity rather than not an antibody response. And just a final slide which shows that they did a study in armadillos in the southern United States, where on the left the control group after 6, 7, 9 months had a lot of nerve damage. The armadillo model is the only animal model in which there is more or less a similar disease to that in humans, and they actually get nerve damage. And on the right, the 3 bars show the nerve damage in the animals that were immunized with the Lepvax. And so they had much less nerve damage. So that, again, our animal models are not great, but they give some hope that we will get a good response to this vaccine. So I just thank the colleagues in Cebu, Seattle, Baton Rouge, where the American National Hansen's Disease Program is, and then also in Tokyo, where they did some of the mouse footpad studies. Thank you.